Sadly, I suppose, it says a bit about the nature of these kind of diseases that I'm the first doctor you hear from. And it's the naked reality of asbestos-related disease, isn't it? Particularly of mesothelioma, that it's not an illness we can cure, but maybe that we can control for some time. And so my role in all that is to firstly show you that from where you're sitting, I probably look like a normal human being. And that will surprise some of you. I went to some effort today. I had my tail and my horns removed prior to driving in so that I wouldn't frighten you all too much. But unfortunately, that's sort of the way my specialty is looked on, that I might be the last doctor you meet before life comes to an end. And so you would like to defer meeting me for as long as possible. And I hope today what I'm going to show you is why you shouldn't do that, and in fact why we can be valuable allies and can be of great assistance to you all in terms of the path that you tread with these kind of diseases. So what's palliative care? And just in case I can't read, I typed it and put it up on there so that you can see it. But essentially it's a way of caring for people where we really want to improve the quality of your life. What we want to do is, if we can, give you better days. But surprisingly for some of you to realise, we can actually give you longer days. I don't mean they last 28 hours, I just mean that you may actually have more of them than you might otherwise have. And the way we look to care for people is different. I think if you think about modern medicine, part of the way we have got to where we've got to, is that bad grammar? Is by doing what's called being reductive, and that is we start off with a sick person, you take a history, you do examinations, you do some tests, we work out it's your liver that's making you sick. So then we might do a liver biopsy and some more tests, and then get out the microscope and then the electron microscope, and then get out the genetics. And if we were to find there was a tumour in your liver, we'd want to know what genetic abnormalities on the tumour's chromosomes are there. And from there we might be able to pick a immunotherapy or a chemotherapy drug which might save your life or prolong it. And at the end, when you're sitting with that doctor who's going to give you that treatment, what he's looking at is the genetic description of your cancer. And I exist because sometimes doctors doing that forget to look up and see the human being. And so you want those doctors, because without that science, we don't have a chance of controlling these diseases. But my role is to bring back the human being so that you are front and centre in what's happening. So in that sense, it's patient-focused care, and it's care that's focused on the people who love you, in my case, hardly anyone, but it's really the people who care for your family and those that are very close to you. The other thing we try to do is be honest, and I think most of us, when you ask people, what do you want to know? Do you want me to skirt around things? Do you want me to use a few euphemisms? Do you want me to say hypertrophic pulmonary osteoarthropathy instead of cancer? Most people say, just give it to me straight. You know, how do you run your life as an adult if you don't have information? So part of our job is to be almost like a translator. And it's where you would say, send in someone who speaks doctor because I don't understand. And we might appear at that time to translate for you. I think along with honesty, though, is trying to be empathetic and understanding and compassionate and respectful. And I think those things too often are missing in modern medicine. And it's again part of trying to bring back the human being in the equation rather than the genetics of a tumour. It's a difficult job. And what I like most is being able to give control back to people. And I don't know if any of you have experienced that feeling that you don't have control of your circumstance. I know none of you will have been to court at any stage, and I do respect that there are solicitors and barristers in the room perhaps, but you know, courts are set up in a way to control us. So they wear different clothes, they talk a different language, the judge is in an elevated platform, and it's all a bit different and it's all a bit bewildering, and you're just shunted through that process. And medicine's the same. I don't like to disillusion you, but hospitals are set up to benefit nurses. They're run by nurses, and doctors and patients are just a pest. And so the danger is in all of that, you lose control of your circumstance. If you think back when you were a child and you had a fight with your mum and dad Could you lie in your bed and have a fight with your mum and dad? You have to stand up, don't you? You've got to meet them eye to eye. How do you talk to doctors in hospitals or nurses if you're flat on your back and they're standing up surrounded by half a dozen team members? It's very disempowering. So part of our role is to return that, help you to be in charge. And with all of that, we're about affirming life, not the miserable sods who, give you an injection of morphine and life comes to an end. What we really want to do is make life as full and as functional and as beneficial to you and your family as it can be. So we make use of stuff. I like to say to people, I'm an allopath. I guess you all know what that is. It's like a naturopath. And people go, oh, that's wonderful. Do you wear a caftan? Have you got some patchouli oil that you might rub on? And have you got a farm at Nimbin? I say, no, I work in a hospital. I give people drugs from a factory. And that's because they work most of the time. So we employ medical technology. So one of my colleagues said, really, we're just handholders and back patters. And sure, we do that and give people hugs too, and it's jolly nice. But at the heart of it, we're still medical practitioners and we're still interested in using medical technology to assist you. And the idea with that is we want you to live, not die. But there's a time when death will come. And we want you to be ready for that. And we want you to be in charge of it. And we want it to happen in the way that sits right with you. And the biggest danger in the Western medical system is that you don't get a say. And so part of the reason I'm standing up here first even is so that you understand that having a say is really important. And I think a lot of you know that anyway, don't you? I think the other thing is that we all die. It's normal. And it's not the enemy. And we don't go around the hospital pumping on people's chests going, live, damn it, live. There's a time for all of us where we no longer survive. And it's recognising that arc of our life from birth to death and being ready for it, just as you get ready for other major events in your life. And to do that from the palliative care point of view, you need a lot more than a doctor with a bad line of jokes, which reminds me, what's brown and sticky? It's a hospital joke, so be wary. It's actually a stick, and that's the level of joke you're going to get from me as the morning goes on. So if we're going to care for the whole person, this sort of gives you a bit of an idea of what we think, how to look after you or how to work with you. The thing we're interested in is your suffering. And suffering is more than just pain, although you can see it looms large in that diaphragm that I stole from a colleague. He's still unconscious, but I got away with it. Pain's a problem with asbestos-related diseases, so it features large. But you can see there's many other aspects to having these kind of diseases. It impacts on your spirit. It impacts on your psychology. It impacts on your family life, on your relationships, on your social life. And they're the things we want to know about. What happens to you as a human being is in all those different areas. I don't just want to know about your pain. I want to understand those other aspects of life. And if we understand that, and we understand how the illness impacts, then we're better placed to help you. We're better placed to help you achieve your goals. And we're better placed to help this not happen, right? Because I've met lots of people where 6 months survival feels like 2 years by the time we've finished with people medically. So it's kind of nice to not have that happen. So where does palliative care fit in? And I think for most of you, the community expectation is that you get dropped off at my ward with about 10 days to live and you don't see me till then. And if we went back 10 or 15 years, that's actually pretty true. That's sort of how things often worked. But I think across the board in medicine, there's been an understanding that what we offer is really appropriate at the time of diagnosis for a lot of diseases. So not waiting till you're coming to the end of life, but working with your oncologist, working with your respiratory physician, working with your GP from close to the time of diagnosis. Not because we want to hurry you along, but we want to make that time valuable, worthwhile, and as free of suffering as we can make it. So this is my important slide, right? You guys individually will be, if you were working with me, you are my boss, you know. The danger in medicine is we assume that we know what's best for you. Oh, I miss those days, you know. Whoa. They took pedestals away from doctors about, I don't know, 3 minutes before I graduated. I never got to hop up on one. I never got to wave to the crowd. No one ever said, "Oh, doctor's orders, I'll follow them." That was only in cartoons and movies. But we make this assumption, "Oh, we'll give you this, we'll do that because I know what you want." Well, we don't, do we? That's just silly. So what we need is to work with you. We need you to be instructing us and telling us what it is you want to achieve. And how do you do that? And really, I've put some simple things up the top, and I'm going to take a risk. Look, the pointer works, it's great. And you've really got to start from thinking, all right, I've got a yucky, that's a medical word, illness, right? What am I going to do? And the thing I would say to you now is to say, well, what are my values? What are my standards? What are the things I've relied on throughout my life when I've had to make judgments? Have I thought about anything else, buying a car, getting married, having children, many, many other things, changing jobs? There are things within you that are your reference point, where you think, what's meaningful to me? What's right for me? What is it that I want with this illness? How do I want to conduct my care? And too often, I think the feeling is, well, you're the doctor, you know what to do, just do it. And people say that, and I think, yeah, all right, I'll do that. And then I think, well, excuse me, but that would me being a dick if I did that. So it's very important that you are instructing us and telling us what it is that you want. So when you think about those values, what's meaningful and proper for you, that helps you to decide, really, what are the goals of treatment? What do you want to get out of chemotherapy? What do you want to get out of radiation treatment? What do you want to get out of immunotherapy? Particularly if you know that this isn't an illness we can cure. This is an illness we might control for a while. And so what you want out of treatment may be very different. You might say, I want enough treatment to go to Singapore to see my son. You know, I don't know why he's lazy, he could come and see you, but anyway, you might want to go to Singapore. Or you might say, we've booked a holiday on the Queen Mary, of course, and it's in 2 months. I want to be well enough to go on that. You might have lots of other goals, but with that in mind, how I want to be treated, what are my goals, what are my aims, then you can advise the doctors treating you, and they should say, well, there are a variety of things we can do. Knowing what you wish, maybe these are the things that could help us achieve that. So much better than them saying, well, I've got some treatment for you, just lie there, we'll stick a needle in and away we go. The other thing is then to say, well, okay, great, you've got that treatment, what's the cost? Yeah, and sometimes it is dollars in large numbers, but what's the cost to you and what's the cost to your family? If you live in Charleville, does it mean you're going to be stuck in a hospital in Brisbane for 2 months while you have chemotherapy and radiotherapy? And maybe if your disease advanced, have we just stolen the 2 best months of your life keeping you in hospital? Does that fit with your goals and your values? So it's important to think, what do I want? How can these guys help me achieve it? But what's the price of using those treatments? What's it going to cost me? And then in the end, does that still marry up with my values, with the things I hold dear to me? And, you know, I can think of many occasions, separate to asbestos-related disease. My dad would be a good example, who said, you know, son, I never want to look like those poor people over there in a nursing home, demented, unable to get out of bed, you know? And in our health, we all know what we don't want to experience in medical care. But too often, the people giving you medical care don't ask what you don't want to experience, and you don't tell. So we just merrily charge on thinking we're doing a great job. You're thinking, how do I get out of this treatment mess? And we're thinking, what more can we do to you to make you feel fabulous, because we know what you want. So it's really important that it's a two-way street and it's a discussion. And part of the role in palliative care is to help that discussion evolve, because we can translate from human to doctor and back again, and that can be very helpful. I think the other thing that we don't think about, because it's scary, is what do I want when I die? And we should all think about that, right? All of us, not related to this disease particularly, but just that's our life. Our life ends for all of us. It's not magic. It doesn't go on forever. So what do we want when we're going to die? Where do we want to be when I'm going to die? Who do I want with me? You know, I don't want the bloke over the road who stole my lawnmower 30 years ago. You know, you need to think, what will that time be like? And if you think about it and you talk about it, you discuss it with your family, with your doctors, with people that you're close to, you've taken the sting out of the tail of dying because you are back in charge. Right? It's not bossing you around. You're saying, okay, if it's coming, here's my rules. This is how I want it to happen. You doctors and nurses, your job is to help me get to that point, to the way I want it done. And too often what happens is that conversation doesn't happen. And you end up in a hospital bed, sometimes in intensive care, which is the last place you should be. It's bright lights 24 hours a day. There's machines that go beep. You've got a hospital gown just covering the front of you and nothing else. I'd like to meet the designer of those things. You know, and you're not you. You've got a name tag on that they have to check to be sure you haven't turned into someone else since the last time they came to the bedside. You know, the men, you can't wear lippy or earrings. It's hard. You are depersonalised. You need to think in advance. What are the limits that I'm willing to tolerate in my treatment? Where am I going to draw the line? When am I going to stop? And it's a team effort. It's something you will do in consultation with the people who love you and the people who can advise you medically. But don't neglect to do it, because the person harmed in the end is you, and that's a great tragedy. And I guess what I would say about thinking about dying, it's like having a baby at home. It's not, is it really? Let's be honest. But it's a bit like that. You know, and as was mentioned earlier, I did used to deliver babies, and that was like riding a roller coaster, a bit scary on occasions. But people would say, I want to have my baby at home. And many, many people say, I would like my life to end in my own home. Now, not everybody wants that, and that I can understand, but people should have the right to make that decision. If you're going to do that, it's like saying I'm going to have a baby at home. I need people to support me. So I need friends and family who love me and have got my interests and, in brackets, the baby's interest at another time. I want them there with me. How do I want dying to occur? Do I want to be awake? Do I want to be asleep? What symptoms do I want to be sure that I avoid? How can we be sure those things are looked after properly? And with that in mind, you need good nursing and medical care. You need people who are able, competent and willing to support you at home. And doing those things, it works. You can die gently, respectfully and peacefully at home. But if you don't think about it, the opposite might happen. And it happens in a yucky way, in a place you don't want to be, with people you really don't want to hang out with, at a time you're not ready for it. So that planning is really important. I think I've laboured the point, haven't I? But I'm going to labour it one more time. So there are ways to formalise that, right? And broadly that's called advanced care planning, and I'm sure some of you already know about that. And that takes a lot of thought and discussion and wisdom from you as a patient, from your family, and from us as people who can advise you. And I had a patient say to me when I asked him what did he want as he approached end of life, he said, I want to wrap it up. I want to be able to say goodbye and leave with a bit of grace, good humour and dignity. And I thought, okay, we can do that. So let's work together that might be our goal. So with that in mind, it's important to think about it, and it's important to tell the people you love. Now down the bottom I've got things, a statement of choices, which is a very easy form to fill out. Your GP should know about it, certainly, so should your respiratory specialist. And an advanced care or advanced health directive. Advanced health directives are a legal document that you can download from the Department of Justice and the state government and get it filled out with your GP and get it witnessed by a JP or a lawyer. The statement of choices you witness with the GP, but it's more you write in what you want. If any of you have looked at an advanced health directive, it's tricky. I've been looking at them for years and I still don't quite understand them. They're hard to fill out. The other one is very straightforward. If you type in statement of choices into Google, it's the first thing that comes up. You can download it off the internet and have a look at it. Now, from my point of view, I say to patients, I don't really care if you fill the form out. What I care about is that you talk to the people you love about the contents of that form and sit down and say, okay, I've been thinking about what I might want as my disease gets worse. So I'm going to tell you now. And you may not have filled out the form, but it's really important your family hears you because they love you, right? And when you turn up in emergency department sick and maybe confused or a bit desperate, you can't speak or be understood, people will turn to your wife, your husband, your children, your parents and say, what does Joe want? And if you haven't had that conversation, the first thought for the person who loves you will be, save him or her, because they're the person I love. And you may be at the point where saving is the last thing you want. But if no one can speak with authority on your behalf, we become like a cat playing with a mouse. You know, we keep treating you and keep doing things. We don't let you go home, but we don't let you die. We just keep playing. And that's a terrible place to be stuck. So these things, I think, are very valuable. And it avoids this, right? That St. Peter sends you back for a little bit more suffering because he figured you haven't quite had enough. So that's in your power, okay? It's important to feel that you're in control. So I thought we might talk about pain a bit. I go from one really happy, cheery subject to the next one, don't I? It's a ball of laughs this morning, but I guess this is something of the reality of what we're dealing with. And the thing about pain is that we're all afraid of it, me included. And I often find myself thinking, have I got the courage of my patients? Could I swap spots here and take this information in, go home and make decisions about how am I going to deal with something I might fear a great deal? And whether it's pain or whether it's loss of dignity, whether it's breathlessness or something else, have I got the courage to do that? And I think it's a tough question, and I still am unsure in myself. So each of you earns my respect, I must say. I think it's a very tough job. So pain doesn't always happen. And I guess that's one of the things to tell you, is that you don't have to have pain. Now, mesothelioma is pretty renowned for it, but in many cases, well, not many, 15% statistics say people don't have pain. So pain isn't necessarily going to accompany you through this illness, but for many it will. And so while we fear it, it's not the commonest thing that happens to people. The thing that's most common, most debilitating for people is fatigue and tiredness. And when you talk to people with advanced disease, that's the thing that distresses them more than pain. They are so knackered, another medical word, they just can't get out of their own way. And that bothers them and troubles them more than pain does. So while we fear it, it's not maybe the commonest accompaniment, but many of us will have 2 or 3 different kinds of pain at any one time. And the source of that pain can come from muscle and soft tissue, like you see on your body, can come from bone, it can come from your organs inside your body, it can come from injury to nerves, or it can be a combination of all those things. And if morphine worked for all the bad pain in the world, I wouldn't have a job. And I'd kind of wish it did, but the reality is often families and patients are surprised, oh, you're getting at the big guns, doctor, you got the morphine, sweet, everything's going to be great, we'll just head home then. And you find it doesn't work. And that's disarming and alarming, not just for patients, but for doctors and nurses as well. Because sometimes doctors don't think. Now that's a bit shocking, isn't it? But they'll say, well, I've given you some painkiller, off you go, don't whinge. But maybe it's the wrong drug for the wrong pain and you don't get relief. And so it's very important that people look at you from the point of view of really being a bit OCD, a bit nitpicky. What's your pain like? Where does it go? How does it feel? What makes it start? What makes it finish? You know, can you sleep with it? What else happens? And how is it affecting how your body functions? And when we get all that information, we're much better placed to prescribe the right medicine to try and help control that pain. And that takes a lot of people. I think the third, I can't see from over here there, there's a bucket load of people who might be involved in helping your pain. It might be someone like me, but it might be a nurse specialist, it might be an occupational therapist, it might be a radiotherapist or an oncologist, it might be a surgeon, or it might be all of us working together to try and get good control. But the outcome of all that is that for about 96 or 97% of people, we can completely control your pain. So that leaves 2 or 3% of people where pain is a big problem. Now, the last paragraph I'll put on there is really, when I say completely control, I don't mean completely remove. And Part of the problem is if you try to abolish particularly cancer pain, but those of you who might have pleural plaques and things like that, you get dreadful, horrible pain, and you can't always make it disappear. So we make a bit of a deal with cancer pain in general. If it will let us, we'd like to get it down to being about 2 out of 10. Now, that number scale is not helpful for some people, but if you imagine you've got a sort of pain where, I'm sure you've all had, where it's sort of nagging away, but you get involved in a TV program or listen to Midnight Oil like before, and if it sort of goes out of your mind, and a couple of hours might go past and you think, I'm okay, or your partner will say, how's the pain? You go, no, it's there, but I'm all right. That's where we want it. And that's what I would call a sort of 2 out of 10 pain. It's not gone, but it's not bossing you around. It hasn't got you in a headlock leading you around the house. It's not stopping you from going out. If you imagine that you've sped through the city at 150 kilometres an hour on your brand new motorcycle and you've been chased by 3 police cars, you've given them the switch, you've got home, you run inside, towelled off, made your mum think you've just had a very peaceful ride home, sat down at the dinner table and there's 2 big thumping coppers banging on the front door. You're trying to eat your dinner, but the coppers aren't going away and they keep thumping on the door. That's not good pain control, right? You're trying to focus on what's important to you, but the banging from the pain doesn't let you get away from it. It's calling you incessantly. And that, in my mind, is like a 4, 5, 6 sort of pain, where you really can't get away from it. And finally, you remember those old, doctor in the house sort of comedies, carry-on movies, where there'd be some hapless, weedy, tiny little guy in a badly fitting army uniform on the parade ground with a giant beefy guy with a huge moustache and a red face shouting at him right in his face. That's a 7, 8, 9 kind of pain. There is nothing in your world but a big, beefy red face putting spit on you and shouting. Pain is overwhelming, and that's where you never want to be. And that's what I would set as a goal, is you want that first kind where it's under control. But the nature of these sort of pains is sometimes they just turn up. You don't have to do anything to provoke it. It just happens. And along with good pain medicine to push that pain down to 2 out of 10, you need additional medicine when it plays up that you get control of it quickly. Anyone played that whack-a-mole game in arcades? You're all too respectful, I know. But little thing pops up, you hit it with a hammer. Another one pops up, you hit it with a hammer. And that's a bit like what we call breakthrough medication. It's pain medicine you take when the pain suddenly arcs up, you push it back down again. And so what you need is a combination of 2 sorts of medicine: long-acting medicine that suppresses the pain, and then quick-acting medicine that chases it away if it unexpectedly turns up. Now, back to that similar diagram to before, pain's not straightforward. And it affects all aspects of your life. And we all know that. You have a broken arm, or you twist your ankle playing soccer on a Saturday, or you have a terrible headache, whatever it might be. It has impact on all these other aspects of your life. It might be culturally not acceptable to show that you've got pain. So you might have to bury it. It might not be allowed in your family, especially if you're the mother, to show that you're suffering. And so it impacts socially and impacts psychologically. You might think, I got this pain because I'm a bad person. And so I deserve this pain because what I did when I was 17. And so psychologically, you may approach the pain very differently to someone who thinks, why has this happened to me? Equally, if you've got other things happening in life, it influences your pain. And you imagine, if you were down at Thredbo or somewhere and you've been skiing, you're in your best snow bunny outfit, I'm just talking to the men, you're at the bar, you're having a drink, you're talking to your mates and you're having a jolly nice time. Somebody walks in with a big Besser brick and drops it on your foot. Hurts like blazes, right? You imagine there's another version of you standing outside in 6 inches of snow, just in your undies. You haven't had anything to eat all day. The wind's picking up, it's getting cold. You've lost your wallet, your car keys, someone's robbed you. The same guy comes out with the Besser brick and drops it on your foot. Who's got the sorest foot? It's the one with all the other stuff happening, isn't it? And so we have to, when we're trying to think about how to manage pain, is what's influencing your pain and what is your pain influencing. And if we understand those things, we have a much better chance of pulling pain into control. There's lots of times patients complain of terrible pain in the night in my ward in the hospital, and the nurses will duly give them the pain relief that works well in the day, and it doesn't work. And they come in the morning and say, we did that, it worked yesterday, it didn't work last night, what's going on? And sometimes it's what I would call a long, dark tea time of the soul, you know? It's the middle of the night, it's dark, there's no distractions, there's no one talking, there's just you and your mind. And the more you think and the more you worry and the more you become distressed, the harder the pain bites. And the answer to that distress is not to give you a drug. The answer is to sit with you, have a cup of tea, talk about what's in your mind, sit out of bed, write it down, talk with your partner. Not all pain is treated with a drug. But there you go. There's a whole pile of drugs, right? I only put that up to show you we are spoilt. So all this stuff up here, they're all different narcotics. And the one we know best is morphine, or know about most, but the one most of you use is probably endone. I would like to point out that actually spells end one, and just think about it. But the strength of these drugs goes from being equal to morphine to being 2.5 times weaker than morphine to being 3,000 times stronger than morphine. So we have an enormous range of strong painkillers. But sometimes they don't work, and you need other treatment. And so the second list I've got up there are medicines we use to help pain that have got nothing to do with pain. So drugs for treating depression, for treating epilepsy, for treating heart palpitations, for treating blood pressure, all accidentally help control pain for some people. So you can end up with a great variety of medication just trying to control your pain. So the point with that is, and particularly sometimes for mesothelioma, pain is very hard to control, and you need a great deal of medication or sometimes a great variety of medication. But you also need to use stuff that's got nothing to do with drugs. And the first lot, I think, that I set up there is things like listening to music, relaxing, using the power of your mind to visualize other circumstances, talking, working with a counsellor, thinking through spiritual issues in your life. All those things can take the sting out of the pain. Maybe only 10%, but it's 10% less drug you've got to take to achieve that. I think the other component with that is that people like physios, occupational therapists have a great role to play in helping you manage that pain as well. And whether that's with physical aids, whether it's modifications at home, whether it's breathing exercises and teaching you how to relax so you don't feel panicky when you get short of breath, all those things make a huge difference. And sometimes it's actually chemotherapy or immunotherapy or radiation or surgery or a combination. So what I've said at the bottom is it's like making a cake. You've got to put all the right ingredients in. If you don't, the cake tastes bad and it doesn't rise in the oven and we're a failure. And so the management of pain in particular is complex, but it's manageable and we achieve good results. So the important thing to know is that almost invariably your pain will be brought under control, but sometimes with considerable effort. Now, I thought I'd bring up cannabis because I thought one of you would bring up cannabis. I've got some, and I've got some at work. I'm the only hospital doctor at the Wesley that prescribes cannabis. I'm the only one allowed to. I haven't been very impressed, is the only thing I'm going to say. When you see in the lay press, everyone hypes it up and it's a wonder drug and it does fantastic things. And I must say I've only been able to prescribe it this year, and I've probably only given it to 18 people since January. But I reckon probably 1/3 to 1/4 of people get a good benefit, and 3/4 maybe it doesn't do much. So it's overrated and it's overhyped and it's not as flash as everyone says. So that would be my take-home message. Having said that, for some people it really does help, and I think it's like all the other medicines we use, it's another weapon we have to deal with these symptoms. And it's just like with any of these things, which weapon do you need, what day, at what time? And so for some people it will be very appropriate to use it, but for others it will be a big disappointment. So I just want you to not have too lofty an idea of what you might achieve if you were to have access to it. From the orthodox prescription point of view, right, the government's a little hysterically scared of allowing cannabis to be prescribed, and so that's very regulated. And certainly if you get a prescription for it, you have to sign a document that says you will not drive your car for the length of time you take cannabis. And for some people, that's a deal breaker as well. because you may well still be quite functional and think, yes, I want access to that, but if you're going to get it from a doctor, that's the deal. The government has said you must not drive. Now, cannabis will stay in your saliva and your urine for several weeks after you stop using it. So if you get drug tested driving and it turns up positive for cannabis, you haven't got a leg to stand on, so to speak, because legally the government said you shouldn't be driving. And you can't say it's for health reasons, it's my doctor gave it to me. You should have been told you can't drive. So that's a pretty big deal, I think. And it's about $200 a bottle, 25 mils, so it's not cheap. Some of my patients I know buy it from Dr. Bob at Nimbin. Dr. Bob's not an actual doctor. And it's $50. So we are not cheap. We are over-regulated, and it doesn't always work. So it's a bit disappointing, I think. A lot of other symptoms I put up. I guess it's important. You may not always experience pain, although it's certainly a possibility. But there are all these other things that accompany having a progressive illness. Things like cough and shortness of breath, chest pain we mentioned, loss of appetite, weight loss, fatigue, and depression. And those things are very, very common. And they can all be assisted and they can all be improved. Nobody has to experience these symptoms without somebody trying to assist them. You don't have to put up with them. They're manageable. And you'd be here for the rest of the day and I'd have to supply pillows and blankets if I went through what we do with all these things. But the important thing is there is nothing that happens in these illnesses that you should not talk about with your doctor, and you should not assume that it can't be helped. Sometimes more than others, but we can do something for everything. It's not like you are just left to your own devices. The other thing I suppose it's important to realise from my point of view is that we're human beings trying to help other human beings, and we don't always get it right. And that happens even in the flood a few years ago with the mud army. Sometimes people just tore out all the wrong plaster, all right, even though they were trying to help. And so we have to be careful from our side that we don't hurt you. And part of that is if we don't listen well enough, or if we're not given instructions clear enough, we don't always get it right. And there's an apology in that, I think, from our area of medical practice. I think other things I just wanted to mention because I need to shut up. There's the cult of positivity. You well recognise that. Don't talk to me about negative stuff. I'm positive. I'm going to survive and I'm going to beat this problem. So I'm going to be very positive. In fact, I'm so positive, I don't want to see you cry. I don't want you to hug me because of this illness. I don't want you to mention a single thing that might make me doubt my positive approach. And the awful thing about that, there is no really positive person still alive at 125. Everybody dies. And being positive, when they've done the statistical analysis, doesn't change the timing of your death. It will not make you live any longer. And you can be glum, miserable, pessimistic, pain in the neck, and you will last as long as the positive person. The difference is the positive person will cope much better with the ups and downs of their life, and much better with the difficulties these illnesses throw at you. So positivity is important, but it isn't a life-prolonging strategy. But it's a quality of life improving strategy if you use it the right way. And that means allowing people to actually talk about the negative side. I don't know if you came with the thought of allowing me to do it, but that's what I've been doing for the last 20 minutes. But it's okay for someone to love you and hug you and give you a kiss and cry. It's important, and what do you get from that is the love and the care of another person. If you say, don't do that, I'm being positive, all you're doing is harming the two of you. And how do you approach the difficult things ahead if you're busy creating a gulf? It's really important to let the people who love you and express themselves, and for you to do the same. You don't put the mockers on yourself. You won't make yourself die any faster. Just like finishing your will won't make you die any faster. It doesn't work that way, but I know everyone worries about it. So it's important to be yourself, to embrace your family and the people who love you. And I always think dealing with these illnesses a battle. You could put your energy in other places. I would like to think what you do is live with an illness that won't go away. A bit like, someone who's come on Airbnb to stay at your place and won't leave, and they're a nuisance, and they're at the table every night, and they're at the table at breakfast time, and you think, well, I've got to make a life with you sitting at the table, so how can I build the best life I can with this person at my table? And it's a bit like that with cancer. How can I live my best with it sitting at my table? I could spend my day punching it on the nose, shouting at it, shaking it, pushing it off its chair. It still doesn't get out of my house. But what I've done is miss a day of living. And I guess I would really encourage you to live rather than just think of it as a battle. Find the way to make life work for you. The other things, I guess, that are important is that those feelings, we live in a society where our individual control is really important, and it dominates the media. You know, you did something, I'm outraged, my rights are my rights, and they trump yours, and I'm going to do it. And it's very hard in that setting to feel I might not have control over everything in my life, and I think that's very distressing. And the same for feeling I might lose dignity, and I might lose, the ability to function normally. I might lose my continence, things that distress each of us. And I have to say, I've met more people who've lost control of all their bodily functions who preserve more dignity and more admiration is deserved of them than people I meet walking in the street. Its dignity comes in many forms, and you don't lose it. It just changes. And I think it's really important to remember it's who you are in here that makes you a dignified human being. And this is the person that gets loved, not whether or not you're wearing pull-ups to go to the loo, although I understand that's very difficult. And it brings us just quietly to the topic of euthanasia, because when I've thought, how can I have the courage of my patients? I think, gee, would I do that, or would I step off a building? Or what would I do faced with this? If I think I've got advanced mesothelioma with difficult pain, maybe I'm a burden on my family, maybe I would like to finish my life. And I don't have an answer for you on that. I know ethically and morally and legally I don't and I can't euthanize people. And to be honest, in my practice, I think we can provide enough care that people don't want to be euthanized by and large, because we can help them with dignity, we can help them with control, and we can control difficult symptoms. But I know you'll all have your own individual thoughts on that. But the important thing with that, it's not a taboo topic. Talk to your doctors about it. Tell them that's the way you think. Tell them why you think it, what's important to you, because it makes a difference how we care for you. Not that we slam the door in your face, but think this man or this woman is thinking, I might end my life because I'm afraid of such and such. And when I say, well, we can help with that. We can modify that. We can do things that might take that fear away from you. But if you don't tell us that's your fear, how do we do it? We don't know. And I think it's difficult because even in countries where euthanasia is legal, Holland, Oregon, all these places, 97, 98% of people don't want to be euthanized at the end of life. They want to live until they die. So I worry sometimes the public debate is, how do we get euthanasia happening? And the truth is 97, 98% of us aren't going to ask for it. And I think we need more funding, better training, and better community discussion about how else we conduct a good dying without the need for euthanasia. And it works, palliative care. These are just papers, but the first one was quite seminal when people pulled out of chemo a bit early with lung cancer. On average, they lived 3 months longer than the people who continued on with their active treatment. They stayed home longer, they had less hospital admissions, they more often died where they wanted to die, and they stayed out of intensive care. And the same thing can be applied to chemotherapy late in the illness. Nobody in the last 6 months gets any great benefit from persisting with chemotherapy. Now that's getting difficult because there are new treatments where we don't know they might work. Like some of the treatments for melanoma now, people look like they're going to die and they just turn around. So it's very difficult, but the research would suggest there's a point where it's time to stop those things. So how do you get it? To coin an ad, basically it's everywhere in big cities. It's a little bit more difficult in rural places. I think it's hard. GP is a good starting point if you want to talk about palliative care or you want to have a referral. Usually your GP can set that up, or your specialist that you might be talking to. And that care is available in the community through specialised nurses, through community nurses like Blue Care, through your GP, and then through visiting specialists who will come to your home, bring specialist nurses along as well. And of course it's available in most hospitals. where people like me work, and both public and private, you can refer yourself to a lot of these organisations. You don't need a doctor's referral. You can just make direct contact. And this is just a bit of a Keith Richards joke we had, Midnight Oil. Poor old Grim Reaper calls and discovers he's actually visited Keith 20 years earlier. You've got to remember what Keith Richards looks like, of course. I did want to finish with a couple of little reflections. The first one is Cecily Saunders, who founded modern palliative care, I suppose. I won't read it out to you because I can't memorise it, it's too far away to see. But the important thing there was how we care makes all the difference. And that's really important for us as doctors. The second one is a Canadian psychiatrist. He has a career based on dignity therapy. Why does a doctor need to invent a therapy that gives people dignity? You don't have to think too hard to think what modern medicine does. And his byline is, it's so easy to dissolve a human being into a patient, like sugar into water. And we want to get you out of that watery solution. And the last one was a colleague of mine in my general practice, a wise old Scotsman, as there always is one hanging around, didn't actually have whiskey before 10 in the morning in his practice. But he said to me one day, years and years ago, people can't die 24 hours a day. And what he meant was, life gets in the way. Your grandchild turns up, somebody phones you, something happens, and all of a sudden, for minutes or for hours, you are living. And so it's important that you're not dying with this disease, you live with it until death approaches. Last thing, this is a book. If you would read it, I think it would be great. And it's just called Being Mortal. And it's by an American surgeon called Atul Gawande. And the point he's making is that fighting the battle to the bitter end has bad results. You need to know when it's time to stop and have the kind of end to life that you wish to have, not one that's imposed upon you. So, sorry, finished.
Thank you, Doctor. Thanks for such a detailed, no, not long, very, very detailed and informative talk on a very misunderstood topic, palliative medicine. So that was, I enjoyed it. Anyone have any questions for Dr. McConaghy? Any questions? Doctor, I do have a couple of quick questions for you, though. You mentioned pain and mesothelioma and how 15% of people with mesothelioma don't have pain. I've been dealing with people with mesothelioma for about 25 years, and one thing I've noticed recently is less complaints of pain. Do you think that's because of better pain medication, or?
Yes, I would say that. Thank you. Well, two things. 15% wasn't specific with mesothelioma. I think the figure for pain with mesothelioma is probably higher. But I do think there was a procedure when I was a younger doctor that was performed at the Royal Brisbane called a percutaneous chordotomy, where a pain specialist would put a knife, very small, very cunningly designed knife, through your skin, in between the bones in your neck, and cut a tiny little area of your spinal cord and take away the pain from the side of your chest where you had mesothelioma. Now, tragically, that's a lost art. That was Tess Brophy, or Tess Crammond, whose name is now over the persistent pain clinic at the Royal. It was a world pioneer, along with one of the neurosurgeons, and that's been lost, and no one in Queensland knows how to do that procedure anymore. Interestingly, we don't find ourselves saying we wish we could still do that procedure, because we've got new medication, new ways of treating things, where almost always, I have asked for it twice in 12 years, we don't need to do destructive things to control the pain. So I think, new medicine and a better understanding of how pain works has certainly made a difference. I think it's much better.
Thank you, Doctor. Just one final question for me. You mentioned that the patient is the boss. And I think you're very receptive to that concept. But how does your average patient get that across to a clinician who might be pressed for time and you're seeing them for 15 minutes, be it 5 minutes, be it a GP or specialist?
Yeah, I think that's very hard. And you're right, I am very receptive to it. That's part of how we practice, and it's not how a lot of doctors practice. And I think you have to speak, you have to tell people, and it's not easy. And sometimes I think finding the right doctor is like buying shoes. You blokes will understand, the first 10 pairs might not fit right, and you've got to find the right pair. And it's the same with your doctor. If you have someone treating you who might be the best specialist recommended in the world, but you cannot communicate, you need to find another doctor to work with. And they need to be willing to listen to you. You are the boss. You are. And it's important that that information's given. You don't have to thump the table, although you might, right? But it's really important that you share that information. This is what I need from this consultation. They don't like that. And if you see a pedestal in the corner, just nick it on the way out, all right? But yeah, it's just communication. You have to keep talking, keep trying, and make sure your viewpoint is understood and well expressed. I think that's very important.
Thank you, Doctor. Any questions? Oh, we've got a question there. Two questions.
Yeah, just had a person in a situation that you're talking about, palliative care. Was told that even though they couldn't speak, their hands are curled up, they're going grey, they could still hear. Is this correct? And when does the brain die?
Yeah, it's hard. We don't really know the answer to that. I guess if you, and some of you may well have been with people at the very end of life, and for many people they are unconscious in the last hours or days before the end of life comes. Sometimes that's purposeful, and that is between the patient, family and us. We have intentionally allowed that person to go to sleep, and sometimes that's a way of getting away from pain that we perhaps can't control. And the nature of dying is that your organs shut down, including your brain, and becoming sleepy and going to sleep is part of the natural process of life coming to an end. We don't know what happens in your brain once you're asleep. There is a research team in Newcastle who have used a machine. It's like, when they do brainwave testing, you see it on TV with all the little things stuck on your head. They have those in operations now, just 4 little ones they stick on. The idea is to be sure you're asleep when you're having your anaesthetic and you're not wide awake, unable to move while you have your appendix removed. So it's to measure consciousness. So they have done some research on people in the hours before the end of life. And about 60% of people, that brainwave study says they are deeply asleep. And that 60% of people I don't think will hear you because they're deeply asleep. So it's like you're in the soundest sleep you've ever had, and the dog's barking and the mower's going and you just sleep through the whole thing and it doesn't bother you. But about 40% of people, there is brain activity, and particularly when they hear the voices of people they're close to, their loved ones, you get little peaks of brain activity even though on the outside they're completely asleep. And we think those peaks of activity aren't long enough to form a complicated thought or to respond to a long question or probably even to make a memory. So just in that instant, they go, oh, that's the person that loves me. And it's gone again. But that's a gift you're giving, isn't it? And we don't know who the 1 and 2 people are who will hear and won't hear. And I think you're much better to assume the person you love hears you. But also, they won't take in a complicated conversation. They won't understand your doctor at the end of the bed talking about what's happening, because people say, come on, let's go outside, or don't want to say anything in front of mum. But they won't be able to put that together. But they certainly will recognise voices. The other curious thing, on every single one of the patients they studied, at the instant or just before death actually happened, those brainwaves peak really high, almost to consciousness, and then disappear. And I have no idea what that is, but I like to think it happens. It just feels good, But we don't understand what happens.
Natalie, I think there might have been one other question up the back there. I think we got time for 2? Okay, time for 2 more questions.
It's only a quick one. Doctor, I just wanted to ask you, because you mentioned about the cannabis as one of the painkillers that can be an option for the patient. How do you know if they overuse, using these painkillers, especially patient that decided that they just live in their own and manage their own thing.
Yeah, I think if you take too much of these drugs, or not just cannabis, but any of them, it becomes very apparent. And there's things that you will notice about that person, some of which are obvious to everyone, and some subtle signs that we would notice first. And that's very important, because when we're using these medicines to try and help, what we don't want to do is steal your alertness or make you confused or cause you to sleep all day. So we have to walk a middle ground. I think cannabis doesn't do much, and I think that's because the government lets me prescribe one where you've got THC and CBD. They're the two major active components. There's 50-50 of each, and they cancel out the fun stuff. So you don't actually feel great, What you feel is sleepy if you have too much. You just get dopey. So from the cannabis point of view, there's no recreational fun in the kind you get from someone like me. I know, I tried. With the others, and all these drugs, it's really trying to find which one suits you. And so there are people who, every single narcotic makes them vomit no matter what we do. And you might pretty early say, why don't we try cannabis? Because you probably won't be sick with that. And so when you introduce these things, it really depends on the individual, what kind of pain it is, how they're coping with the medication they've got, and whether we think something can be added in that might be of benefit. The other thing, the way cannabis is given in the orthodox way, it's an oil that you swallow, and the onset of benefit takes between about 4 to 5 hours. So it's not like if you smoke it, it impacts on you in about 2 minutes, but as an oil, it takes hours and hours. So you have to take it regularly, morning and night, every day, to suppress it rather than just have some when you think you might need it. So it's a different way of using it as well.
What's your view on electronically implanted devices to control pain?
It's tricky. I suppose quickly, there's probably two sorts really. There's a thing called a spinal cord stimulator, which looks like a little centipede, really, really small, and it gets laid along your spinal cord, and there's a battery and a control box gets implanted in your body, and you have a remote control that you can operate. And for some people's pain, that works quite well. It's not usually used in cancer pain specifically, because very often, if pain's awful, people's survival time isn't such that the cost of tens of thousands of dollars probably doesn't actually benefit the patient enough. But for persistent pain and things that might be like pleural plaques or something like that, where you have pain for many years, that's one of the options you might have. It drifts out of my area of expertise and becomes the domain of anaesthetists, particularly who do persistent pain treatment, but that's probably the commonest device. The other one we do use occasionally is where you put a very fine tube in against the spinal cord, like a piece of cotton, bring it round under the skin and around to the front, put a little device here where you can attach a pump, and you can either give people medicine like an epidural 24 hours a day through this little device, or you can pay a lot more. For $25,000 you can have it implanted in your tummy. And we use that very occasionally, but it's not common, but it's available.